Hi there everyone, this is Judge Lackman, and in this video I'll be covering a topic that's become rather controversial in our present era. It's the subject of vaccines, and here in particular about the research concerning their role or effect in regards to child mortality. The real big push for getting the whole population vaccinated, for mandating vaccinations, tends to be based upon the premise or assumption that vaccines are effective and that they are serving a role of reducing deaths in children. So people that are upset with those who are skeptical of vaccinations often accuse them of in some way causing children to die or allowing children to die. This, of course, is based upon that assumption that these vaccines really are effective and really are serving that purpose of both reducing childhood illnesses and deaths. In fact, if a vaccine were effective at stopping a particular childhood illness, but at the same time it was associated with an overall increase in deaths, then people would think twice about wanting to use that. They wouldn't consider that vaccine really a public health benefit. It might be temporarily reducing the cases of a particular illness, but the overall or global effect of it would be something perceived as negative. So we need to look kind of comprehensively or holistically at any of these particular topics or subjects, looking closely and carefully at the research that's been done, how that research is being carried out, what research methods are used, what data collection methods are used, and how things are being interpreted, what sort of hypotheses have been generated, what alternative hypotheses are being considered or not considered, so we can go in depth with some of these things about how valid or reliable the research actually is, or the conclusions drawn from that research. A lot of data can be collected and various correlations can be cited, but there are so many different factors and variables present and things that researchers aren't able to control that they may draw conclusions that ultimately are not consistent with the full set of information or all the different types of research that are being done. So in this video, I'll be looking at kind of a tale of two studies or two research articles that look at vaccines and child mortality. So we're going to go into those studies now. Let me go into the view where I can see them on my screen. And I'll be posting links where you could find these studies yourself. So the first one here is called Vaccination and All-Cause Child Mortality from 1985 to 2011. Global Evidence from the Demographic and Health Surveys. This is published in the American Journal of Epidemiology. And the authors here on this are Mark McGovern and David Canning. So we're going to see what this says about the research they've done and the conclusions that they draw. The abstract here says, based on models with calibrated parameters for infection, case fatality rates, and vaccine efficacy, basic childhood vaccinations have been estimated to be highly cost-effective. Now, remember, this is based on models. It's not something that's really been proven in a controlled way. We estimated the association of vaccination with mortality directly from survey data. So survey data means that surveys are given to the public or to healthcare professionals, and people fill in those surveys. Using 149 cross-sectional demographic and health surveys, we determined the relationship between vaccination coverage and the probability of dying between birth and 5 years of age at the survey cluster level. Our data included approximately 1 million children in 68,490 clusters from 62 countries. So they're gathering together here a lot of data from a variety of sources, dozens of countries, in fact. So they're putting together data cumulatively from a variety of populations. We considered the childhood measles, bacillus, Calmette-Guerin, diphtheria, pertussis, tetanus, polio, and maternal tetanus vaccinations. Using modified Poisson regression to estimate the relative risk of child mortality in each cluster, we also adjusted for selection bias that resulted from the vaccination status of dead children not being reported. Childhood vaccination, and in particular measles and tetanus vaccination, is associated with substantial reductions in childhood mortality. We estimated that children in clusters with complete vaccination coverage have a relative risk of mortality that is 0.73 times that of children in a cluster with no vaccinations. Although widely used, basic vaccines still have coverage rates well below 100% in many countries, and our results emphasize the effectiveness of increasing coverage rates in order to reduce child mortality. So their research is looking to support this hypothesis that the vaccinations are contributing to a reduction in child mortality. Now that number 0.73, what that means is that for every one child who dies in the group that are not vaccinated, that only 0.73 children, statistically speaking, would die in the population that has the complete vaccine coverage. So they're looking at two kind of extremes. One extreme is complete coverage, meaning the children have received all the officially recommended vaccinations, and then they're comparing that to the children with no vaccinations. And they've collected that data from many different countries and put it all together to create this cumulative statistic. So their interpretation is that the vaccines are having an effect to reduce mortality. Unfortunately, when we look at how research is done, we recognize that there are a variety of other variables or factors that may be correlated with the variables that are being looked at, which are not being in any way controlled or measured. So in this case, we'll note that they were doing this research looking at many different countries, and some of those countries would be nations such as America or England or France or some industrialized country where there's a pretty high standard of living, where there's good access to health care for pretty much all of the population. And then there are other countries being looked at where most of the population may be impoverished. There may be a lot of malnutrition. There may be wars going on in particular countries where things are very unsafe or unstable, and it would be hard to deliver vaccines or other types of healthcare or food to the population in those areas. So those factors can be correlates that in some way affect the outcome variable, in this case, child mortality. So do we know if it's the vaccines that are actually affecting the children's health and mortality, or is it some other variable that tends to correlate with the vaccine coverage? In other words, there could be a lack of vaccine coverage due to factors that are also causing a lack of safety, of stability, of proper sanitation and nutrition. So it's easy to misattribute things if you're not able to really look at all of these different variables. So I'll go a little into the additional portions of the study. We just went through the abstract. Let's see what else these authors have to say. They say that there is evidence that vaccines are effective against specific diseases such as tuberculosis, measles, and tetanus in children. Increases in vaccine coverage have therefore been seen as an important strategy for reducing infant and child mortality rates. There has been a series of coordinated global efforts to increase immunization rates in developing countries as a means of achieving improvements in child health, including the expanded program on immunization and the Global Alliance for Vaccines and Immunization. The period from 2011 to 2020 has been termed the decade of vaccines. The coverage of vaccinations is measured by the proportion of children receiving 3 doses of the DPT vaccine by 12 months of age has increased substantially from 5% or less in 1974 to 75% in 1990 and 84% in 2013, albeit with important regional, national, and subnational variation in achieved coverage. Increases in coverage in Africa were achieved with a series of supplementary immunization activities in the late 1990s that were successful in reaching 24 million children between 1996 and 2000. Almost 20 million children failed to receive all 3 doses of the DPT vaccine in 2010. A third of those children were in Africa. So there's significant weighting of this data toward Africa in terms of those who are not exposed to the full vaccine coverage. And they were mainly concentrated in 10 countries. In addition, other vaccines have lower levels of coverage, with much lower rates for the measles vaccine than for the DPT vaccine. Although the number of vaccine-preventable deaths is large, and of course that's their assumption, that those are vaccine-preventable deaths, a lot of people wouldn't agree with that. The proportion of deaths caused by vaccine-preventable diseases appears to be relatively small. For example, measles accounted for just 4% of all deaths in children younger than 5 years of age in the period from 2000 to 2003, and tetanus accounted for an additional 3%. These figures had been reduced even further by 2008. Nevertheless, studies of the cost-effectiveness of vaccinations in which only the association with disease-specific mortality was used found it highly cost-effective. So disease-specific mortality means how many children are dying from that particular illness, which the public health authorities are giving vaccines for. However, there is potential for routine vaccines to have an impact above and beyond the expected association with a specific disease. The introduction of the measles vaccine in some African communities in the 1980s led to a far greater reduction in overall child mortality than would be expected if it just affected mortality from measles alone. Similar large decreases in the incidence of all-cause mortality were found after the introduction of measles vaccination in Matlab, Bangladesh. There is also some evidence that the Bacillus calmette-guerin BCG vaccine is protective against neonatal mortality, as well as some suggestion that DPT vaccination might increase mortality. Notice they're admitting here a particular vaccination might increase mortality in some settings. The hypothesis that vaccines have non-specific effects on mortality has received validation in animal studies in which a plausible mechanism was demonstrated. Administration of the BCV vaccine in mice led to trained immunity via epigenetic reprogramming. That's what they claim and believe. Of course, another hypothesis is that the changes in mortality are not due to the vaccine at all. They have to do with other public health improvements that naturally tend to accompany the availability of vaccines and vaccine coverage. And this is something that authors like Neil Miller have looked at going back well over a century, seeing how improvements in overall public health seem to provide a better explanation for the decline of diseases than do the vaccine programs. Moving back to the article here, despite recent progress in reducing the probability of dying between birth and 5 years of age expressed per 1,000 live births, hereafter referred to as the under 5 mortality, there has been a renewed focus on implementing interventions that would allow countries to reach the target of a reduction in child mortality to 2/3 of its 1990 level as set by the 4th Millennium and Development Goal. Increases in immunization might provide a highly cost-effective mechanism for further reducing child mortality rates. However, many studies on the cost-effectiveness of vaccines have relied on calibration studies and simulation exercises with measures, let's see where we are, of the association between vaccination status and mortality, often taken from specific cohorts in localized areas. There are likely to be important differences both across and within countries in terms of the effectiveness of vaccination. One issue is how vaccines are administered, a factor that could potentially affect vaccine efficacy. For example, there is substantial variation in the timing of vaccination in low and middle income countries. The second issue is that the actual effectiveness of a vaccine might be lower in practice in large-scale implementation than in small-scale studies because of failures of the cold chain storage and handling. A third issue is that the effectiveness of vaccination in reducing child mortality may depend on other factors. For example, the socioeconomic status of the family and the child's nutrition. Now, that's an important factor that they're sort of acknowledging here, but they're not considering if that factor is actually the major or true cause of changes in mortality rather than the availability of vaccines. From a policy perspective, it's important to understand whether previous findings from randomized controlled trials and observational studies based on specific cohorts can be generalized to diverse populations that experience different levels of economic development, disease environment, and healthcare systems. With some exceptions, there have been relatively few previous studies in which the relationship between basic childhood vaccines and all-cause mortality have been examined with population-based data in more than a limited number of countries. Most studies have been based on data from a single location. The advantage of our approach is that we used nationally representative data from multiple countries that reflect a wide variety of populations and are likely to have good external validity. Of course, you kind of dilute your ability to observe what's actually going on by bringing all those different populations together into the one study. Now, they say our data contain information on all 5 basic vaccines and mortality data for children until they are 5 years of age. Our methodological contribution is that we introduced a correction for potential selection bias induced by missing data on children who died. I'm not going to go into their explanation of how they attempted to correct for that lack of data on the vaccination status of children who died. We're just going to continue further here. So scaling down to the results here. We're going to see how they came to that number of the 0.74. So they found that in their data, for each child in the non-vaccinated or under-vaccinated population who died, only 0.74 deaths occurred in the full vaccine coverage population. They say our results imply, now imply doesn't mean prove, it implies based upon their interpretation that vaccination coverage has a substantial association with under 5 mortality at the cluster level, particularly for measles and maternal tetanus vaccination. These results are consistent with recent evidence of the nonspecific effects of vaccines from previous observational studies, animal studies, and randomized controlled trials. So they believe there are likely to be substantial reductions in child mortality associated with further increases in vaccination coverage, particularly additional immunization associated with measles and maternal tetanus in sub-Saharan Africa, where vaccination rates lag behind those in other regions. Well, the reason they lag has to do with other factors in that environment, and perhaps those other factors are the true reason why mortality is higher in those populations. So it's not really proven that vaccines are the true factor or variable that's affecting mortality here. Remember, this is epidemiological data. It's not really a solid placebo-controlled type of clinical trial that directly measures the effects of a particular treatment or intervention. Since we've gone through this study, which looks at all this data from all around the globe compiled together, I'm going to shift now to another study. And this other study is not global. It's actually looking at a pretty large data set here in the United States. So this is an abstract from an article from the journal Vaccine from 2017. And this is called Patterns of Childhood Immunization and All-Cause Mortality. So we're looking at the same combination there, immunization or vaccination, and all-cause mortality in children. So here their background to the study reports that evidence supports the safety of the recommended childhood immunization schedule as a whole. However, additional research is warranted as parents refusing or delaying vaccinations has increased in recent years. All-cause mortality has been identified as a priority outcome to study in the context of the recommended immunization schedule. Methods. We included children born from January 1st, 2004 through December 31st, 2009, enrolled in the Vaccine Safety Data Link from birth through 18 months of age. We examined vaccination patterns during the first 18 months of life among 8 vaccines and identified deaths occurring between 19 and 48 months of age. We excluded children with complex chronic conditions, contraindications to vaccination. So they're acknowledging that there are contraindications to vaccination even in conventional medicine. So why would you be mandating absolutely everyone get them? And continuing here, and deaths due to injuries, congenital anomalies, or diseases with onset prior to 19 months of age. We calculated mortality rates among children with different patterns of immunization and incidence rate ratios using the Cox proportional hazards model for children vaccinated according to the schedule versus under-vaccinated children, adjusting for outpatient healthcare utilization, influenza vaccination, sex, and VSD site. Results. Among 312,388 children in the study, 199,661, or 64% of the total, were vaccinated according to the schedule, and 112,727, that's 36%, were delayed or not vaccinated for at least one vaccine dose. Of 18 deaths eligible for analysis, 11 occurred in children following the schedule, that's 2.28 per 100,000 person years, and 7 occurred in under-vaccinated children, that's 2.57 per 100,000 person years. Mortality rates among children following the schedule were not significantly different from those of under-vaccinated children when excluding deaths with unknown causes, as well as when including deaths with unknown causes. So, whichever way they tabulated that, they couldn't find a significant correlation here. So that was a pretty large sample, well over 300,000 children, and they're comparing those fully vaccinated according to the schedule and those who were under-vaccinated, which could include some who didn't receive the full schedule, as well as some who may not have received any vaccinations at all. We don't really have a breakdown there of to what extent they were under-vaccinated based upon the schedule. Now in this study, we're seeing that there's really no evidence that the vaccines are reducing mortality. And this study is done apparently here in the United States, where we have kind of two different ends of the spectrum in terms of reasons why children are not receiving vaccines. One factor would be situations where children are just not getting access to healthcare or medical services. It could be children who are living in remote areas or in great poverty, children in very unstable living situations. They may have parents who are moving around a lot, things like that. So that's the ones kind of on the lower socioeconomic end of the spectrum. But then you also have a lot of well-educated parents who are researching vaccines, who are interested in alternative medicine and different ways of looking at these issues, ways that may contradict what conventional medical doctors are advocating. So those parents tend to be more on the upper end of the social economic spectrum, and they're also in some cases keeping their children from receiving the vaccine schedule. So those two ends of the spectrum, the lower SES and the higher SES, may in a sense be balancing each other out. It's really hard to know. We can't really prove how those subpopulations are affecting this data. What we do see is that overall, for this pretty large population, the vaccines don't appear to be associated with a reduction in child mortality. So discovering that in this industrialized country compared to what's happening in Africa, where they're finding that significant correlation, would seem to suggest that the correlation between vaccine coverage and mortality is not actually due to the effect of the vaccines. The vaccines themselves are not apparently preventing deaths. It's likely other conditions that tend to coexist with lack of vaccine coverage in impoverished countries that are creating the conditions for those greater deaths to occur. So perhaps all of the PR, all of the information that's been promoted to the medical profession and the public saying that vaccines are necessary to prevent childhood deaths is not based on solid science. It's based upon a particular interpretation of data where alternative hypotheses have been ignored, where adequate, more thorough investigation has not occurred. And at the same time, there's a lot of other data showing potential health hazards or adverse effects occurring in a small percentage of individuals who receive vaccines. So if people are looking at this in terms of cost-benefit or risk-benefit, all of these factors need to be considered. There's also the issue of what ultimately supports our immunity, not just to one particular pathogen, but to illness in general. If we think about stress, nutrition, and those types of factors, we can see that they play really a critical role. A vaccine can't actually build your immune system. All it can do is stimulate your immune system based upon the stress provided by that vaccine and its ingredients. So you have to have at least a somewhat healthy immune system that's functioning in order for a vaccine to actually stimulate that immune system to do what it is naturally able to do anyway. The whole idea or theory of providing vaccines is to give that stress or stimulus associated with a particular pathogen under a controlled condition so that your body will develop antibodies to respond to that particular microbe so that if you're exposed to it naturally at some future point, your body will have kind of a heads up or head start on responding to it and addressing that potential threat. That's the basic idea of what vaccines are supposed to do. However, if we are healthy, if our body is well nourished, if we're not overstressed, then we naturally respond well to these microbes anyway. We naturally build our own immunity, and when we are exposed to them, we won't get sick. Just because you're exposed to a particular virus or bacteria doesn't mean you're going to get sick. In fact, most of the time when people are exposed to these things, they have a natural healthy response to it, and they don't show any sign of illness. So it's really those other factors, those other stresses or lack of nutrition, things of that nature that are leading toward the condition of symptoms of illness. If we focused as a population on public health, we wouldn't be focusing so much on trying to use vaccines. We would be focusing in a more global way on supporting our overall health and well-being, building up our immune system with good nutrition, with healthy living environments, with a reduction of exposure to environmental toxins. We'd also work on alleviating conflict in our communities, whether it's small-scale violence like gangs or domestic violence, or large-scale violence like civil wars or international wars. So if we create those healthy, stable living conditions, the disease epidemics somewhat naturally disappear. This is, in fact, what has happened historically. If we look at the diseases that vaccinations have been developed for and immunization campaigns have been implemented toward, we find that they were naturally going away anyway, even before those vaccines were introduced en masse. It didn't even matter which country was being looked at, whether a country was instituting the immunizations or not, the disease was still dissipating. In fact, there were diseases that vaccines were never developed for, which still went away on their own. So if we introduce a vaccine and the disease goes away, how would we really know that it's the vaccine that's leading to the waning of that epidemic? It's really difficult to prove that. Yet that assumption has been made, and it's been the basis for public health policy for many decades. It's time for us to look at things more critically, to rationally consider all these different variables, all these factors affecting our health, all the details of how the immune system works, of how it responds to vaccines, the inherent limitations in the effectiveness of vaccines at preventing future illness, and of course the documented adverse reactions to vaccines, which tend to be underreported, leading to a skewing of the data there, where more people are actually having negative effects or consequences from vaccination than the mainstream data or public health authorities are recognizing. There's a bias or prejudice present in how that data is collected. There tends to be an assumption that vaccines are not the cause of later adverse symptoms. And so without any proof that they're not the cause, the medical community tends to document those particular symptoms or illnesses as having some other cause or unknown cause. So if we have data that's not accurate or properly collected from the start, then all of our future research and studies based upon that data will be flawed or faulty. For those of you that are interested in holistic health and natural healing, you're invited to view more of my YouTube videos, as well as to visit my website, phinsights.com. That's phinsights.com. For now, I'd like to wish each of you a wonderful day. Namaste.